Infant Jaundice by Jordanna, Taylor, and Joel.
This is Jordanna. She was born with a yellow tone to her skin. Her parents were very worried and unsure of what they should do. Upon consulting a doctor, Jordanna was diagnosed with infant jaundice.
Infant jaundice, also known as physiological jaundice, is a disease in which a baby is born with a yellow-orange hue to the overall appearance of the body. It is the most common newborn disorder, affecting approximately 60% of term infants and 80% of preterm infants. The abnormal coloring is a result of excessive circulating level of lipid-soluble bilirubin that accumulates in the skin. As red blood cells die, they are phagocytized by macrophages. Hemoglobin is broken up into heme and globin. From there, heme is broken up into iron and proteoporphyrin, which is converted into unconjugated bilirubin, a lipid-soluble substance. Albumin binds to unconjugated bilirubin and is transported to the liver. Once in the liver, it is taken up by hepatocytes and conjugated to uridine glucuronol transferase, also known as UGT, making it water-soluble and turning it into conjugated bilirubin. Conjugated bilirubin is secreted into the bile caniculi and then to the bile ducts. From there, it is sent to the gallbladder and stored as bile. When you eat something, the gallbladder secretes the bile, which contains conjugated bilirubin, into the duodenum. As it moves through the duodenum, it is converted into urobilinogen, UBG. UBG undergoes oxidation, converting it into urobilin, which is excreted and responsible for the brown color of feces.
Some of the urobilinogen is recycled and is reabsorbed into the bloodstream, most of it going to the liver and a small percentage to the kidneys. The small amount that goes to the kidneys is excreted and responsible for the yellow color of the urine. The relative immaturity of the newborn liver, those born before 38 weeks. When the liver does not have the ability to remove the required amount of bilirubin, jaundice can occur. The shorter lifespan of fetal red blood cells are contributing factors to hyperbilirubinemia, an excess of bilirubin within the blood, in the newborn. The faster red blood cells die, the more bilirubin will be created. This is made worse by the lack of maturity in the liver. During pregnancy, bilirubin is excreted from the fetus via the placenta. The removal of bilirubin in the newborn infant is the transition phase from placenta to liver. Once again, this combined with the relative immaturity of the liver can lead to jaundice. Key concepts. Jaundice is a homeostatic imbalance in which there is an excess bilirubin in the liver and blood. For one reason or another, the body is unable to remove bilirubin as effectively as it should. This leads to the bilirubin being deposited and collecting in certain areas of the body, such as the sclera of the eye and the skin.
Bilirubin usually travels through the blood using transport proteins. It will typically bind to the plasma protein albumin.
High blood bilirubin levels also increase the level of bilirubin in the extracellular fluid. This is the primary contributor to the change in pigmentation. Unconjugated bilirubin is a lipid soluble, and this allows it to cross the blood-brain barrier. Once across the blood-brain barrier, it gathers in the cells of the basal ganglia. This is known as kernicterus, and if left unresolved, can result in extreme defects such as seizures and muscle spasms.
In infants, jaundice is easily treated and rarely a cause for concern. In most circumstances, primary treatment is more than enough. Primary treatment includes sufficient nutrition, regular bowel movements, and normal fluid volume. If all of these parameters are met, the liver should be able to remove the required amount of bilirubin from the body. In more severe cases, phototherapy is used. This is when the infant is exposed to fluorescent light in the blue wavelength. The bilirubin in the skin absorbs the light, which is then converted to a water-soluble isomer, making it easier to remove from the body in the stool and urine. In cases where the infant and mother have different blood types, the infant may have developed antibodies that contribute to the breakdown of red blood cells. In this case, the infant will receive injections of intravenous immunoglobulin, which reduces the level of antibodies. When severe infant jaundice does not respond to any previous treatments, the baby may need an exchange transfusion of blood. This involves repeatedly withdrawing blood, diluting bilirubin and maternal antibodies, and then transferring the blood back into the baby. As a result, Jordanna underwent multiple sessions of phototherapy immediately after she was born. She was placed in an incubator for a week, and she was not allowed to be held and was constantly fed. After 1 week, she was able to return home, but went for several checkups and blood tests over the next year.